Dr. Ozowara, thank you for joining us here on the Science of Psychotherapy podcast. It's so great to see you.
It's great to be here. Thank you.
And Richard here on the sort of a little bit of a distance from Matt on the Sydney side of Australia, but I've been very excited to get to speak to you, and lovely to meet you. Some people listen to us on the podcast, but we also have some people watching on the video so they can see you have a fabulous bookshelf. My God, I'm embarrassed about my background, but anyway, it's really lovely to have you here and to talk to you about the work that you do.
Thank you so much for having me. So I am a psychiatrist by training. I spent a number of years in medical school and residency. And then after that, I took on some academic positions for a few years. In the last couple of years, I sort of transitioned into more on the corporate side of things, focusing on how we can best deliver care to those who are underserved and provide access to care.
That's wonderful. And I understand that there's a number of areas that you sort of focus on, you specialize in. Do you want to sort of touch on what they are?
Sure. So one of the areas that I've focused on previously was more on the inpatient side. So for somebody who has depression or bipolar disorder or schizophrenia, who needs to be hospitalized for any number of reasons, maybe they're suicidal or maybe they're just suffering from an exacerbation of their illness. Those people get admitted to the hospital and they see a psychiatrist like me, where we get them started on their treatment and then get stabilized and back into the community. In the last several months or a couple of years, I've been focusing mostly on the severely mentally ill population. So that includes schizophrenia and bipolar disorder, among other conditions. And right now, I'm the senior medical director at Valera Health, where we are actually providing ways to engage those individuals and deliver highly effective care, whether it's through frequent contact through case management or individual therapy or group therapy. We're sort of helping people transition through their journey and their mental illness towards stability.
I'd love to get into schizophrenia, if you wouldn't mind, up front. And would you mind stepping us through the whole approach to schizophrenia from the initial diagnosis, and then what happens in terms of treatment protocols and stabilization?
Yeah, because I can just add my bit in to which is what I was going to say, because I had a Facebook discussion or a discussion group, and someone was being very opinionated about a lot of things, and then I brought up schizophrenia, and they said, oh, well, of course, if I had a schizophrenic, this is a psychotherapist, if a schizophrenic person came in, I'd immediately refer them to a psychiatrist, and being very sort of a little pompous. And I just wrote back and said, well, how would you know? And I think this is something that's interesting. So in the context of what Matt's asking, as they come in, how do you screen? What are you doing? So there's this to help a psychotherapist assist their capacity to recognize that this may be a component of their client's issue.
Sure. So there's both two very interesting and very great questions. The first is kind of stepping back and looking at what schizophrenia is. And the way that I would conceptualize it is a diagnosis or disorder of mostly distortion of reality and some cognitive disturbances, right? So that distortion of reality, or the psychosis component, really takes the form of either hallucinations, like hearing voices that aren't necessarily there or seeing things that aren't necessarily there, and also delusions. So thinking something that is true when it actually isn't. That's, for some people, harder to figure out because there's no way to know for sure if something isn't true, right? So it's pretty hard to challenge somebody on that one, right? Yeah. And I once had somebody say to me when I was seeing them in the emergency room is, it's not a delusion if it's true. I said, well, that's a fair argument. I can't really argue with that one. But it's really someone who has an unusual belief that just really can't be based in reality. And so that is kind of the psychotic symptoms. On the other side are the cognitive ones. So that's really a disturbance in how they think. And the problem with that is that you can't really know what somebody's thinking, right? You can't read minds. The way that you can kind of get a sense of that is to look at their speech and look at their behavior as a reflection of how they're thinking cognitively. So the disorganized speech and disorganized behavior in combination with the delusions and the hallucinations really make up the bulk of the what we call positive symptoms of schizophrenia. And when we say positive, we're not thinking these are great symptoms to have. It just means that they're
Yes,
the presence of symptoms that should not be there, right?
Yeah, so positive is the addition of the symptoms that are in addition. Yeah.
Right, exactly. On the other hand, there are some negative symptoms that are a little bit harder to catch because they are symptoms that are lacking. So people who are not motivated, who are not social, who are very withdrawn, they're not doing the normal things that a person would typically be doing. Those are really the negative symptoms of schizophrenia. And as it turns out, those are much harder to treat than the positive ones. And in terms of kind of assessing and thinking about it, one is you have to look at the symptoms at face value and say like, okay, this person is maybe not telling me that they have paranoia, but I can tell based on my interactions with them that they seem very concerned that somebody is out to get them. Now, again, we can't know for sure if there is really somebody out to get them, right? But based on the kinds of things that they're saying, we might be able to figure that out. One of the things that we find is often the case, especially earlier on in the illness, is that the person who is experiencing those psychotic symptoms often don't have the awareness to know that that's what they're experiencing. So you might get into conversations or unfortunately even arguments with somebody where you're trying to tell them, no, that's not actually happening, when they're very convinced that it is. And that is probably one of the hardest or the biggest barriers to getting them the treatment that they really need.
Yeah, I remember that extraordinary scene in the film A Beautiful Mind, right, which was talking about that. And when the chap came in to say, you're up for a Nobel Prize, he turned to one of the other students that obviously he knew was a real student and said, excuse me, is that man really here? Yeah. So he'd learned how to, that he had delusions and that he needed to manage that. Right. So I suppose now that's really getting to a question of treatment and how you help people engage.
Exactly. So the treatment is crucial. The mainstay of treatment is really with antipsychotic medications. And those have been around since about the 50s or 60s, starting with medications that were heavy in terms of side effect burden, trying to come up with, from the first generation of antipsychotic medications, which had a lot of side effects around movement disorders and the like, to what we call the second generation antipsychotics, which reduced some of the first generation issues, but created issues of their own, including things like weight gain and everything that comes with that. And so over time, we've sort of moved towards the second generation antipsychotics, but like I said, they're still with a considerable amount of side effects for the most part. So the treatment really kind of gets at figuring out which one of those medications is going to be your best bet. We know that the medications are actually pretty effective. That's not the issue. Some are a little bit more effective than others, and none of them are 100% effective. What we do see, though, is that getting someone to stay on the medication is really the hard part. We saw in the CATIE, there was a CATIE trial, I forget the acronym right now, but this was a study done a few decades back where they compared that first generation antipsychotic. They used one in particular, which had a balance of the various side effects. They compared it to a few second generation antipsychotics because they wanted to know if all these new drugs that were coming out were actually any better than the older ones, especially because whenever a new drug comes out, they cost a ton of money, right? And so we wanted to figure out, like, well, is it worth switching over to the second generation antipsychotics? What they found is like the medications actually performed pretty similarly. There was one, olanzapine or Zyprexa, that performed a little bit better than some of the other ones. But what they found was that one was also the most associated with weight gain and sedation, right? And so that, one of the interesting things about that study is the outcome that they were looking at was how long somebody was willing to take that medication, which is kind of an interesting outcome, right? And the reason that's important is the way that you know if a medication is going to help somebody is A, does it work? And B, will you take it, right? No medication, no matter how effective it is not going to be a good one if somebody stops it after a couple of days. So the Zyprexa or olanzapine showed some promise that when you're balancing how effective it is versus how tolerable it is, then it was a little bit more worth it than some of the other ones, right? So one of the difficulties that we have in psychiatry just across the board is getting somebody to stick with treatment. And that probably depends on how far along they are in the process, right? If somebody's in considerable distress and they're acutely symptomatic so that their suffering is so apparent, you give them a little bit of medication, their suffering goes down, right? Because their delusions are getting better. They're probably more likely in some ways to stick with medications for the short term. Over time, as they get better and the symptoms start to go away, there's not an incentive, right? All that they're experiencing is the side effects that are happening or accumulating over time, and not necessarily realizing all of the benefits that they're getting from the medication.
So I'm guessing that in a supportive role, when we're talking to psychotherapists, that this is one of the key aspects is to maintain the psychopharmacology.
Right. So there are a couple of things that can be helpful. One is to kind of reinforce compliance, and that can be done in a number of ways. Is to sort of help the person look at the pros and cons of taking the medication, help them develop insight into their condition and the ways in which their psychotic symptoms were affecting their ability to function, right? So for somebody who maybe they weren't psychotic, but they were acutely manic, and I had somebody who bought and crashed an Aston Martin. And I said, okay, so that happened. You were manic. Do you want to take your medications now? That might be an easier conversation to have. Even with that case, that person is still not willing to take his medications, which is a testament to how serious the condition can get and how impaired the insight can be.
And it might be that a therapist, a psychotherapist, is seeing the patient more often. Right. They might have weekly or fortnightly visits, whereas the checking on their medication and those processes, and even if they're taking an injection, these long-term injections now, there's sort of a month between visits to the medical expert. So the psychotherapist could be a very important person in the management and also the observance of the changes.
Exactly. Both of those things. You threw me off by the use of fortnight, which we don't tend to use over on these parts. But yes, it's absolutely right. You might be seeing the person 4 times as frequently as the psychiatrist does, and monthly visits, especially depending on the insurance and the availability, you might be looking at like every other month for a psychiatrist or every 3 months for a psychiatrist. And if you as a therapist are seeing this person week after week, you'll have a better trusting relationship, and you'll be able to notice differences that the psychiatrist probably wouldn't be able to pick up on right away. So that's an excellent opportunity to not just think about saying like, you got to stay on meds, you got to stay on meds, you got to stay on meds, but just figuring out what the person wants and what the barriers are. So if it's somebody who says, look, I want to be able to work again, that's my goal. You think about, well, what's getting in the way? Is it the illness? Are you getting so paranoid that you're leaving your job and getting fired left and right? That's one thing. Or is it the treatment? So maybe the illness is under control, but your medications are so sedating that you are sleeping in and not getting to work on time, right? And if you're looking at both of those aspects, both the illness itself and its treatment, and figuring out what are the barriers to achieving what this person wants, then you build that alliance with that individual, and you can help them kind of achieve their goal by addressing which area is the most of a hindrance to their recovery and their goals.
Yeah. Now I'm wondering, going back to diagnosing, there's obviously a spectrum of things that we're looking at. Symptomatology is from mild to severe, I'm assuming. Now, is there any correlation between the severity of symptoms from the outset to compliance, through therapy? So The most
So,
severe clients,
yeah.
are they the most difficult when it comes to keeping them on meds?
That's a great question. And you have to think about it both from the inpatient and the outpatient side. They can be the most difficult to stabilize. I don't necessarily think that it always translates into being the most difficult to maintain. I think it depends on how bad the illness made them and what the cost of having the illness might have been, right? And so the worse the outcome was when they were acutely ill, maybe that serves as sort of a deterrent to stopping the medications, right? I also tend to see people who are on the more intelligent side kind of not only form some sort of self-denial, but like try to get other people around them to sort of not see it as big of a deal as it is, right? And so they're able to justify their symptoms. They're able to talk themselves out of medication or manipulate people into lowering the doses of their medications, or what have you. And I think that that tends to be one of the biggest barriers. And those are the people who typically have the most to lose, right? So an executive who has a manic episode might have more serious consequences in some ways than somebody who, isn't working at the time.
Yes, and it's important there that there's a bit of in the conversation where we're discussing both schizophrenia and this bipolar type of aspect, and they have a crossover. It's a bit of a Venn diagram with that. And a term that we use with a number of these areas, with autism, with ADHD, with schizophrenia, with bipolar, is this term high functioning. So this is what you're saying about the more intelligent. But functioning is the key goal of the individual.
Well, I think one of the things is to think about where they are in the journey of their illness, right? So somebody who has a first episode is going to require a lot more intensive work around both identifying what's going on, developing some insight, and then coming to terms with the condition, right? So I think I tend to see more people earlier on who have a lot of denial, and those people are having a difficult time adjusting from life as usual to now life managing a new condition. Just as if somebody was diagnosed with like diabetes at an early age or cancer at an early age. It's a transition, it's a role transition. And so this new role can look a lot of different ways. I think a lot of people don't want to have the label of having a psychiatric illness. And I think that is one thing that presents itself as a challenge. And I don't think that people like the idea of committing themselves to long-term treatment, right? I can't even take, something like an antibiotic for a week. That's a commitment for me, right?
Yeah.
So taking a medication once or twice or three times a day, indefinitely is a hard thing to, well, no pun intended, swallow, right? But I think one of the things that I help people figure out is, look, this is not a death sentence. This is not the end of the world. This is something that we're going to manage together. And I like to use the term management because it is not something that you have to undergo or ignore or anything like that. You just have to figure out how to treat it like you're treating any other condition that you're experiencing. And one of the things that can help is to sort of reestablish what the goals are, see if those goals are reasonable. And like I said earlier, help them meet those goals as effectively as you can. Over the course of the illness, I think what happens, and you had mentioned this earlier, is people start to have some recognition of what's going on. They might not fully say that this is like, psychosis or what have you, but they'll say something like, okay, the voices are back, I'm hearing them again, I'll take the medication. And usually what we'll see after, the second or third or fourth, unfortunately, episode, they kind of have a sense of what's going on, what needs to be done to get out of the hospital, and how to move forward.
What do you find in the area of group work or perhaps some collaborative work between patients? Is that something you encourage or that emerges spontaneously?
Both. I think, it's funny. Most people don't want to hear it from a psychiatrist. I'm sorry to say that, but they like to hear things from their peers, right? So one of the things that we see a lot of the times in the hospital setting is a lot of the hospital-based work is group therapy. And I've seen over the years that people tend to do better and process differently and come to acceptance faster if they see someone else who's like them, who's getting help and is understanding their own illness and saying, hey, I'm managing this, so can you. And I think they're much more attuned to that. So the more that we can encourage people to find communities and groups of people who are experiencing the things that they're experiencing, the better.
In terms of intensity and frequency of care, now I would imagine in the normal medical sort of situations that these people could fall through the gaps, and that we need to create, which I think you have, systems where that frequency of care is provided. Do you want to speak on that?
Absolutely. So one of the biggest gaps in care that we see is immediately after a hospital stay. So if you imagine somebody, gets so paranoid that they barricaded themselves in the room and they stopped eating for 3 days, and they're to the point where they either need to go to the hospital or something terrible is going to happen. They get into the hospital, they get started on medications. One of the wonderful things about medications for bipolar disorder and schizophrenia is that they're reasonably effective, and you can stabilize somebody in a short-ish amount of time. And short is kind of depends on who's asking the question or looking into it. And then you transition them to the outpatient setting, right? So you schedule them an appointment with a psychiatrist and a therapist, and you say, I wish you the best of luck, right? But what if that appointment is 2 months out? What if that person, as soon as they get out, maybe they couldn't fill the medication at the pharmacy? Maybe they had a side effect that they couldn't tolerate and they didn't have anybody to talk to. Maybe they just needed some encouragement to say like, hey, this is okay, we'll get you through it, right? And so we see a lot of people drop off after the first 30 days or so of their hospital stay. And then what happens? They get back into their illness, and they get back into the hospital. And it can be both a financial burden to society, but also a cost to that individual whose life is repeatedly disrupted because the treatment is just not going well, right? So what we have figured out are models to ensure that people get connected to care very quickly, and in fact, within 7 days of their hospital stay. So what we do is we work with various hospitals. We're based in New York. We partner with them to say, hey, refer these people to us. We will do an assessment. We'll make sure that they're safe. We'll check in to see how they're doing with their medications, to see if they have any questions. And then we can get them started with a therapist who has experience working with this population, and somebody to prescribe medications who can see that person actually frequently. So what we do is we say, look, you just got started on a new medication. You're just entering treatment. Let's do your therapy once a week. Let's do your medication management once a week or once every other week. And let's also get you a case manager for touch points in between, who can ask you like, hey, how did your appointment go? Hey, I saw that you missed with your therapist. Do you want me to help you reschedule? Or are you having trouble getting to a pharmacy? What we found in that program, that model, is that we've not only reduced hospitalization readmission rates so that the number of times somebody has to go back in the hospital goes down. When they do go back in the hospital, they're actually there for a shorter period of time because they're a little bit more stable than they would be otherwise. And it's been very successful. The other cool thing about it is we do the entire thing digitally. So we are a virtual platform. We do our sessions by video. And most people would think that that would be suboptimal for this population, but lo and behold, it actually works, I think, better than in person. And part of that is by doing it virtually, you're eliminating a couple of barriers to accessing care, right? One is transportation. If somebody can't get to their appointment, they're not going to go, right? And two is just logistics, right? So if they can do it literally from bed, then they're much more likely to comply with their appointments than if they have to like figure out where to go and what to do and all of those things. So we make it a lot easier for people to transition into outpatient care.
One of the things we've found in some of the looking around, particularly from in some of the work I've done as a supervisor, talking to therapists who experience this sort of work, and also some therapists who did their sort of field work, was homeless shelters. That homeless shelters dealt with this really, they're sort of at the coalface. And there would be, that is an interesting place. Is there any integration or interaction with those sorts of areas where a lot of people with mental health issues tend to congregate?
Right. And so that's a good point. A lot of homeless individuals do experience mental illness. And so that might be a contributing factor to homelessness, or it could also be the result of being homeless, right? It's more likely to cause certain conditions. We do try our best to interact with homeless shelters, but it's hard because, you know, if you're trying to do things virtually and you're trying to access a shelter and get a hold of the person who's in that shelter, it becomes complicated. But as much as shelters can do to integrate behavioral health within the shelter system itself, the better off people are going to be. So that might be just having a case manager who is staffed at the shelter, right? And that person can kind of help them figure out if they need to get appointments with providers, if they need to get help with housing, if they need to get help with like food stamps, that kind of thing. And I think if we focus more efforts on that population, I think they would be much better off.
One of the things that's in your bio, so where we learn about you as we go, but you do, you have an attention that you give to the LGBTQI community. And it always interests me, the difficulties or the differences or the specific types of responses and approaches you have to have with different areas of the community, but particularly those who also have the additional difficulty of being a minority group, or perhaps even certainly in some areas of different countries, they can actually be an oppressed group. So what have you found in your work there? Is it everybody's has a similarity, people have differences, or just individuals? What is your experience working with these varied communities?
Right. And I think that there are certainly some similarities, but I would characterize every individual as an individual. There are some people who are in various stages of their transition, if they're in the transgendered community. And so in working with that community, what we see is trying to figure out their own suffering, their own experience, but also thinking about the impact that society has, right? So even within the field of psychiatry, we've kind of changed our definitions and our diagnoses of like homosexuality, for example, gender identity disorder versus gender dysphoria. And so you've seen the DSM change over the years as a reflection of new data, new research, and just societal changes in general. But it's interesting because in the trans community, it's one of the conditions where society's impact on that individual is just as important as everything else. And so creating a safe place for the LGBTQ community, I think, is first and foremost the most important thing, because without that safety, it's really hard for them to recover from any mental illness that they're actually experiencing. And two is to sort of think about what are their short-term and long-term goals. If your goal is to help them through the transition process, for example, thinking about different experiences that they face and how to overcome those obstacles, I think is really important.
Yeah, looking at some of those what the individual has to deal with.
Right.
I mean, I've got a particular client whose functions reasonably well, but if I were going to use the categories that the DSM gives us, I would say that she has a degree of ADHD. She is probably on the spectrum to some degree. She has childhood trauma, probably complex trauma, and probably sexuality based, but certainly in dominance based because of the ADHD and the ASD. The teachers were always putting her out of the class. So we have developmental frustrations. We have a number of therefore anxiety and depression. It's not bipolar, but she rises and falls on that. And blow me down, but she's now suffering because of other, obviously, biological issues. She's had some Epstein-Barr in her youth. She's got long COVID. And so employment is now very, very difficult. Now this is a pretty highly complex case, and I've got to tell you what I'm learning, and I'm listening very, very carefully to a lot of things you're saying, because I'm also looking for delusional aspects. So you get sometimes these patients who have this rolling series of interruptions. They seem to manage one thing and then another thing pulls them down. What sort of experience or thoughts or words of wisdom for me?
I'll have to charge you for that one.
Quick session.
Well, I think it's hard when there's multiple competing things, and I think this is true, especially primary care. You sort of identify with the individual, what are the one or two most important things to you, right? And then figuring out as a clinician, what are the most important things to you as a clinician? And for you, it might be, what is the most dangerous thing, right? So somebody who is suicidal, that might be top priority for you, may or may not be top priority for them. And so you have to sort of align with coming together and figuring out how to prioritize these things. And then it's just one thing at a time. There are some conditions in psychiatry that we can treat sort of simultaneously. You start one medication, you get a pretty reasonable and quick response, you add on another medication. I think in the psychotherapy realm, it's going to be a lot of work focusing on like, okay, maybe now is not a great time to focus on trauma. Let's figure out how to work on coping skills. And then we can sort of revisit the trauma once we're out of this particular crisis. One of the issues that you probably experience that comes up is one crisis leads to another crisis, leads to another crisis, and you never get to the thing that you actually wanted to address. But that's kind of the nature of things, I suppose.
So you mentioned suicide there, and if I could just backtrack a little bit in our conversation about schizophrenia. Now, is suicidality, is that a serious concern in the schizophrenic population?
It's a very serious concern. So we know that there is at least a 10% rate of suicide attempts or completed suicide in that population. One of the things that we see as risk factors is, suppose somebody is in college, they have their first psychotic break, maybe they're at Harvard or Stanford or what have you, and then you got to pull them out of school and they can't really return back to their normal functioning. There is this phenomenon of what we call post-psychotic depression, where that experience, whether it's the medications that's bringing them down or just the whole role transition, as I was describing earlier, is really a setup for somebody experiencing a really severe depressive episode. And that's a very important time to kind of make sure that that person's okay. And so that's one of the times where suicidal ideation and behaviors is more likely to rear its ugly head. The other, I would say, is really when anybody has voices that are telling them to harm themselves or harm their other people, and they don't have the insight to know that they are voices. So the psychosis is very strong, but the awareness or insight is lacking. That is also, a high risk category and one where you should be very careful in assessing for suicidal ideation.
And I would imagine this is where your case manager is absolutely vital for that continual contact. Yeah.
Right.
Okay.
Wonderful. Yes, I was very interested in it was an anecdote from one of my supervisees, but it was at a homeless shelter, and one of the members, and she was doing her sort of prac work there, so thrown in at the deep end, and she was told that this was not uncommon. But certainly one of the guests was what freaking out, we just simply was just unable to cope, was losing, was being violent to others, violent to themselves. And they had a particular medication. It was a drug, we call it a depot. I don't know whether that's, but it's just a
long acting adjustment.
Yeah, long acting, and it's a multiple dose thing. And the purpose of it is to just bring everything down, because of course everything's beyond management. And she said that so the guest came down, settled, and of course became quite sort of sedated, quite dopey. But she sat there, and after it was only about 15 or 20 minutes, and this guest turned to my supervisee and said, "Thank you." It was a really wonderful expression of the importance of interpersonal engagement. And it was because the injection, yes, all the stuff, yes, but that someone was sitting with them at the point where they were able to express their gratitude. And gratitude, we know, is a wonderful thing to have.
Yeah. No, I think that's absolutely right. I've definitely had cases where, in the midst of their angst and suffering and psychosis, they're having a distortion of reality for sure, but they're just not able to sort of recognize that they actually need treatment. And so sometimes it's necessary to give that treatment, even if sometimes it's against their will, knowing that, it might be the right thing to do so that they can get the relief of their suffering that they really need. I've had plenty of people, actually I had one case in particular where she developed her first manic episode. We treated her for a little bit. We thought she was stable enough. She got discharged from the hospital. She came back a couple of weeks later, and I said, "This time we're gonna keep you here as long as we possibly can." The first minute that she saw me, she said, "Oh, it's you again." She walks away and slams the door in my face, and wouldn't talk to me. It was so uncooperative, and we worked together for a few weeks. And boy, I can tell you, I was dreading every time I went into the room to talk to her. But it was necessary, right? And so what happened was, I was in the hospital setting. We moved her to the intensive outpatient, where you go for 3 days a week for 3 hours a day. I was her psychiatrist in the intensive outpatient program. I don't know if it was the masochist in me or what, but I agreed to do that and sort of follow her for the next few months after her discharge from the hospital stay. We got her boyfriend to come to some of our sessions. We got her mom to fly from China to come see her. We got her sister to fly in from New York. We had a family session, and every single person, including the patient herself, was very appreciative that we actually kept her in the hospital as long as we did, and sort of forced her hand into sticking with the treatment. So that was incredibly rewarding. I don't know how I would be able to do that again, but I think that it's a testament to exactly what you were just saying.
Yes, and sounds like you need to employ a lot of creativity on the fly as well.
Yeah, absolutely.
Yeah. So as we sort of round this out to a close, I'm just wondering, is there anything sort of final words you want to leave for our listeners?
One thing that we sort of touched upon, but we didn't explore too much, is somebody's feelings around not just their diagnosis, but their treatment, the medications. I'll give you an example. So I had someone I was treating in an outpatient setting. We were doing a combination of medication management, but also some psychodynamic psychotherapy. And during the course of our treatment, I switched him from an SSRI over to a different medication. And what he told me one day was he was able to cry. And I was like, well, is that a sign that you're getting better or you're getting worse? You don't seem to be too bothered by it, right? And so what we started to unpack was, when he was growing up, his parents over and over and over told him, or delivered the message, that it was not okay to cry. And so when he was on the SSRI, one of the common kind of side effects, for better or for worse, is that it reduces your ability to, cry. And so what he found was, even though he found the medication to be helpful, there's still something missing, and that experience of intense emotion was what was missing. And that was part of the thing that was keeping him down. So when we switched to another medication that was less likely to do that, he was able to experience the emotion in a way that he couldn't before. And that in and of itself, I think, made him feel a lot better. So talking to somebody about their experiences around and psychodynamics around the medication, I think is really, really helpful.
Yeah, and again, being open and creative, I think, in your approach and being flexible. Wonderful.
Yeah.
Yes, and of course, responsive as
yes.
is something that we're investigating a lot, and we think needs to be given a greater deal of attention, I think, in the future of therapeutic work. That individual, and that's a wonderful sort of description, that little story you did there, of the balance between management and self-effectiveness and self-satisfaction. Right. Beautiful. Thank you so much. Thank you so much.
Yeah, it's been a pleasure to meet with you guys.
Thank you, Dr. Ozowara. It's been great connecting with you and hearing all about schizophrenia. And we wish you all the best with everything that you're doing. Thank you so much.
All right. Thank you.
Bye for now.